Hey, hi, Sabina Khan. Thank you so much, Dr. Khan, for joining us live for an interview. This is actually my first time meeting you. Can you tell me a little bit, just share a little bit more about your practice because I have so many questions.
Yeah, and thank you so much for having me. And I've been following you for a while, so it's such a pleasure to meet you and get to speak with you as well. So my background, I'm a women's health occupational therapist. So clinically, this is my area of practice. So I work with women across the lifespan, and that includes women who are pregnant and postpartum. As of recently, I've adjusted my focus a little bit more towards research because I work full time in academia. So I'm hoping to produce a little more research in this area regarding occupational therapy and our role within maternal health. But yeah, my area of practice, I've worked with women, as I said, who are pregnant postpartum. As of recently, I've also shifted a little bit to working a little bit more with teen moms specifically. Um, so a lot of my work with teen moms is predominantly life skills training. So it started off with pelvic floor rehab, which is usually the reason people seek occupational therapy services or physical therapy services when they're pregnant postpartum, or at least from my experience that I've seen. But our focus has shifted a lot, especially with the teen mom population, because there's just a lot of other factors involved. There's a lot going on there. Sometimes there's a lot of history of trauma. So there's a lot more psychosocial, mental health, and emotional support that is provided.
I spoke about this publicly, but the youngest teen mom I've treated after C-section in the hospital was 13 years old. And so tell me a little bit about your practice because I saw a post where you actually posted a home visit. You actually visited your teen mom at home. Tell me a little bit about what you do in the realm of occupational therapy or just with life skills training and all of that.
Yeah, so the girls we usually work with, the youngest I've ever worked with is 15, and then many of them are 16, 17-year olds. So these are girls who are in their junior year or senior year of high school. So a lot of the home sessions integrate physical rehab into them depending on what the issues are, because every person has, their own unique situation. But then it also involves, I would say the predominant amount of our sessions is spent on understanding how to plan for babies. So I start working with them in pregnancy, and it could be at any point during the pregnancy. But our goal is usually to ensure that these girls can graduate high school, that they can hopefully apply to college, that they can apply to trade school. Some of them not to do that, and they choose to instead pursue, getting a job afterwards, but they don't have experience with resume writing, filling out job applications because of their age. They're just so young. So a lot of it is training them on understanding what is involved in that process, understanding how to fill out a job application, understanding how to prepare for a job interview. So it is those unique life skills that they just can't get from in other areas of life. So, for example, a lot of the girls I work with have these strange relationships with their parents. A lot of them come from broken households, single mom households. And then maybe their moms are working a lot. Maybe they just don't have the best relationship. So they don't really have that full support that I guess they're hoping to have. So a lot of the role also as an occupational therapist working with this population is to be that support person for them, to be that bridge to help them understand how to navigate life through this transition that they're now going through. So
This
yeah, so
is
it is budgeting, even problem solving can be very challenging, which we think, us being adults, like, okay, that's, what would that entail? But really just breaking it down and understanding and mapping how to solve a problem and being able to prioritize your time, not just being able to jot down your appointments in an appointment book or a planner, but actually being able to prioritize all of the tasks that you have to do by deciding, okay, this should be allotted to my priority one or priority two, which is high priority or urgent. priority 3 and priority 4 are things we can always put off if we don't have time for it. So just really going through and understanding how to do that to make sure that they can meet their goals. Because that is the goal, to really for them to get through, to be able to complete school and not have this transition in their life stop them from doing the things they want and need to do.
Dr. Khan, how early do you start with these moms?
Like I said, it's the earliest I've ever worked. The youngest I've ever team mom I've worked with is 15. Um,
Not in age, but during pregnancy, first trimester, second trimester, immediately after birth.
yeah.
When does occupational therapy come in your practice?
So occupational therapy can start as soon as a woman finds out she is pregnant. Um, because a part of occupational therapy is also being able to prepare for that birthing experience, being able to prepare for being a parent, being able to prepare for understanding how to bond with your child, understanding infant development. So it can start as early as conception. Depending on what the needs are for the person and what they're looking for and what kind of support it is that they need. But yeah, I've written in the past about this and how we can contribute even in the preconception stage for women who are trying to conceive to have a child, and what kind of lifestyle management strategies we can provide to help facilitate that when it comes from that health management standpoint. And then once a woman has conceived, being able to carry that pregnancy through and have a positive experience. And our goal is to mitigate, those factors that can impede that, the optimal health. So if there's stress involved, being able to prepare someone for what they have to expect in the near future. And then that can help bring that anxiety down, those stress levels down. It can help people plan earlier for that, that experience.
And then how about postpartum?
Yeah, so postpartum, same thing. So it would continue. So I actually really appreciated reading a lot of your work and what you've put out there, because I think you shed a lot of light on this and how, early intervention and is really just key to early recovery and for the best outcomes after birth. But even in that postpartum period, there's just so many different areas depending on what an OT wants to specialize in. So of course we have pelvic floor rehabilitation by itself, which is so important, but also once again, being able to intervene when it comes to that the postpartum mother maternal infant bonding relationship. And we have a lot of assessments out there that we can utilize that can help us understand where the mother is in that relationship with her child and how to help facilitate and improve that relationship as well. So we have like infant development. We have an area within lactation support. So like one of the teen moms that I work with recently has said her focus right now is on increasing milk supply. So of course, some of these areas require extra training. So it may not be an area that a generalist, an occupational therapist as a generalist, or occupational therapy practitioner as a generalist would want to venture into without that training. But with that training, there is that area, of course. So if someone did want to go into that area as well with lactation support and positioning as well. And then once again, being able to really look at, when we talk about performance patterns, we're looking at habits, roles, routines. So we're really analyzing what is a part of someone's day-to-day activity. So looking at what that involves on their daily routine and understanding how this experience, whether they have an injury after birth, whether they have to just manage now taking care of this infant that they have, they've had no prior experience or education on, and understanding how to navigate through their daily routine with or without that support. I know when I had my children, my first child, I had a very different experience from my second child. Just it's night and day. And with my first experience, I had generally it was a positive experience, and I had a strong social support system. I had my mother-in-law, I had my mother come and visit me and help. And it was fine. And I thought I was, good to go with, when it came time again for me to have my second child. And I don't know if it was specifically the birthing process, but I had a very different experience giving birth that second time, and both were vaginal deliveries. But I had excruciating tailbone pain afterwards, and then I developed inguinal neuralgia also. So what I found afterwards is that I had trouble even just sitting on the bed. Like I would have to really guard myself and layer pillows before I sat down. And I remember saying this to the hospitalist that helped deliver my child. And he said, well, this is just an outcome from, birth, and this should go away soon. You just gave, you were in labor and you just gave birth. So I thought, okay, when I go home, slowly it'll get better. But I had it for weeks and I didn't know that it was a sign of a problem. I just thought that this was, something that maybe I was a couple years older. So maybe this is normal. And then slowly later, I started having that nerve pain shooting down my leg. And it didn't start immediately either. This was about a month afterwards. So around 4 weeks when I started having it. And it persisted off and on for several months. And it would come and go, but it was exceptionally bad when I'd have to carry my child around, probably because I was carrying weight on top of that. And so just considering that, and every birthing experience is so unique. So everyone has different needs. And that's why I truly believe that everyone should at the very least have a screening or an evaluation after birth or in that postpartum period. Because I know you've highlighted it many times where, sometimes women go 6 weeks, 7 weeks without seeing a healthcare provider once they're discharged.
Dr. Khan, I was at AOTA and I cannot believe I missed the opportunity to meet you. But in the audience, after our presentation that I did with Jessica Hammond and Laura Rowan of Essential Pelvic Health, there was a question from an audience member, a CODA, probably actually a student, CODA, who was asking, well, what would we do in that immediate postpartum period? And so, taking your example that you just described, you yourself, with this pain that the hospitalist tells you it should go away, but then a month down the road, you're still experiencing it quite significantly. What I did with that CODA's question was I just turned it back on them because as a physical therapist, I really struggle with telling other disciplines what they can do. So I asked her to just tell me, what would you do? So, Dr. Khan, in the hospital with you as an occupational therapist, what would you have wanted to happen?
I think what would have been really great was to have someone come in and educate me, maybe, or provide support to me on different adaptive ways on performing whatever tasks it is that I needed to do in that hospital room. And that can involve things like how to get out of the bed, to minimize my pain and discomfort. If I need adaptive equipment, for example, there's a lot of adaptive equipment like OT could provide women who are in these situations. Things like such as for lower body dressing, bathing, toileting, all of these areas were impacted for me. Showering, and these are all areas where OT can help facilitate function. So we can help women who are not able to make it to the bathroom in time, or start educating them on certain deep breathing exercises. We can educate them on adaptive equipment and tools to utilize in the hospital, as well as for once they go home, or make sure that they're set up before they go home. So if they need a raised toilet seat, for instance, because they can't stoop low to sit onto a standard toilet seat because of that pain that they're getting, whether it's that tailbone pain or pain elsewhere, then maybe those are recommendations that they need before they're discharged from the hospital, so that they go home and they can have access to that equipment when they are discharged and when they are home and they're on their own. So definitely, with any recommendations for equipment, recommendations on different strategies to utilize and different techniques,
Yeah.
also different energy conservation techniques, and yeah.
How about at home? Like, where the real battle for you began, would you say it was after you left the hospital and then you actually had to manage yourself and your baby?
Yeah, so I would say yes. In the hospital, it was challenging, but I had support from the nurses who were there and my husband who was there. And then when I went home, my husband's a cardiologist. He didn't have a paternity leave. He has a very busy schedule, so he's not around. And then I had my mother temporarily there in the beginning, and then she lives in New York, so she had to fly back to New York as well. So I was essentially on my own then, taking care of my infant and my child while navigating, these discomforts and this situation. And it is also very, very stressful when you're feeling pain and then you have your infant who's crying, who wants to be held. But then when you hold your infant, it's not just holding. Sometimes that requires standing and walking and rocking. And then that puts you in pain. So yes, if I had the knowledge then that I do now, or if I had an OT who was able to provide to me that knowledge and that education of what I could do and the strategies I can utilize and any equipment that can help, I feel like that would have made a huge difference in my recovery, in my stress levels, and how I felt I was doing as a mom in this stage. I felt like I was, it's a very isolating feeling when you feel like you're letting your children down, when you feel like you're letting those around you down. You want to believe that you can do it. And it's just not fair to have someone feel like, they're not doing their best when they really are doing their best. You just haven't set them up to succeed in that environment.
Exactly. Dr. Khan, when you presented your research at AOTA just a few weeks ago now, and then also just with your written work, what's the overall sentiment from your audience? Are they surprised about all of the breadth and depth of occupational therapy practice in maternal health? Are they excited? Are they a little more reserved? Do they pull away? What's the sentiment from your audience?
I see a lot of practitioners and students who are present that I feel like a light bulb goes off where they're like, wow, I wasn't aware that we can be in this arena. I don't think that there's a lot of knowledge out there, especially in entry level occupational therapy programs, on the area of women's health and what occupational therapy can provide. It's interesting because I was also doing this study with one of my colleagues at the university. Her name's Dr. Vanessa Grijalba, and as well as with another colleague. And we were looking at the impact of high risk pregnancies in women of color. And one of the areas we were looking at were barriers as to why they have not received occupational therapy services, if they've heard about occupational therapy. And something that has come up time and time again that we've seen is that there's just not awareness on what occupational therapy can provide to someone who has given birth during pregnancy or during postpartum. And that comes sometimes also from their healthcare providers not providing any education to them also about that. So yes, I think we need more research in this area, but I also think that we need to put more knowledge out there. So that includes, being able to present on what we know occupational therapy can do, how occupational therapy can benefit this population. And I think a part of that is raising awareness.
So it sounds like it's a marketing issue.
I would say marketing is definitely part of it.
Or even branding. I mean, if you think about it, is this more an issue that people don't know what occupational therapists do, including occupational therapists?
Yeah, I absolutely think that you bring up such a great point, because I think that it comes back to academia and what we learn in occupational therapy graduate programs as well. Because I think a lot of programs focus on developing therapists as generalists. They don't consider women's health. Even though there are clinicians that are currently working in acute care hospitals, serving in OB units, working with women who have delivered children. So it should be integrated into academia and entry level programs. Um,
And I
yeah.
do. I push back when you have a list of questions that I want to get to about research, but I push back on occupational therapists and physical therapists being graduated as generalists, but not actually being prepared to treat this population, which, if we just looked at surgery and post op rehab alone, Cesarean sections are the number one surgery performed in the United States and globally in terms of major surgery. So, as a generalist, I would expect a rehab therapist to be prepared to treat someone after a major abdominal surgery with the added component of caring for their child. And so I push back as to why we're not doing that at the university level. I don't understand it from a post op perspective.
Yeah, no, I completely agree with you. And I think that we are starting to see a bit of a shift where we see some programs offering electives in this area. Although I agree with you, I believe that this should be something that is taught and covered, and we should be introducing case studies in standard occupational therapy education. It shouldn't have to be an elective. Women's health should not be an elective, it should be mandatory because there are occupational therapists right now working with women. Women's health should not be looked at as a specialty area.
I totally agree. So
Well,
let's talk a little bit about your questions because, in terms of research, you are my go to. You are who is kind of the missing link for me in proving the testimonials are actually based in data and in evidence based research. And we don't have that. We don't even have a single case study, Dr. Khan, a case study, right? Which is what considered the lowest form of evidence to prove that someone who is seen an occupational therapist has had a better experience during their postpartum recovery stay in a hospital. There's not a single case study that shows that, occupational or physical therapy, of just the experience that someone had having a physical therapy consult during their hospital stay after birth. And so
right.
to me, the field is wide open, but in terms of the hospitals that I work with and have worked in, why is that data so hard to get? It's just beyond me. It's beyond me. And it's not for lack of trying, but it really is just like dumbfounding to me as to how difficult it is just to produce research on what we've already been doing.
Yeah, I completely agree with you. I don't know. As someone who's just kind of come into this arena relatively new, wanting to help facilitate more of our role in speaking to what our role is in this area, and I'm one of my goals is to help produce research because I do see that there is this scarcity of research that's out there about occupational therapy, and yeah, I think that's definitely one area that I think I'm hoping to get a little more involved in.
Sure. And so, Dr. Khan, I asked you to allow me to interview you based on just questions you were asking me, because I was like, these questions need to be discussed in a public arena. So, one of the questions that you asked me, and that really, really stood out, were about rehab hospitals that actually extended years out from the data that we have now. I've only been tracking the hospitals that I know, and that's from therapists who have responded to my requests of, hey, does your facility offer occupational or physical therapy after birth? And so we only have, and I put the slash in there because as of 2023, or whenever that initial study was created from or collected from the March of Dimes, there's only a little bit over 2,100 maternity hospitals in the United States, right? And so out of those 2,100 maternity hospitals, 44 that I'm tracking, at least from the surveys that I've collected, are providing some form of rehab after some type of birth experience, a lot of them being cesarean sections only. So someone in your case with a pudendal nerve issue would have never been seen. A lot of our teen moms would have never been seen. Someone even with preeclampsia, if she had a vaginal delivery, would not be seen. And so even the hospitals that are reporting that they offer some type of rehab service is very scant in terms of the population. One hospital I think reported that they're only seeing women after primary C-section who fit a certain criteria, a certain BMI or a certain comorbidity. So not even everyone after their first time major abdominal surgery is being offered rehab. So from your question, it's like, actually, can you help us determine what would be a good starting place, even for those hospitals that are not seeing population, so that they can just do a compare contrast study, something
Yeah.
very low level, very easy just to put out into the field.
Yeah, no, I agree. I think definitely producing studies speaking to the benefits, if there are, excuse me, if there are occupational therapists providing services, and then using that information and looking at, well, what are the outcomes of this? Are we seeing positive outcomes? And that putting that into publication will definitely absolutely help.
So
Um,
I'm going to put myself out there, Dr. Khan.
yeah.
I'm going to totally put myself out there because I think that just the average therapist needs to hear this. So I've written two commentaries, which we know doesn't even hit the mark on evidence-based research. And I submitted my a case study that we did with a mom after an emergency section. In the midst of COVID, she had an emergency section at 28 weeks due to COPD related to COVID. And so she had to be intubated. We saw her at day 5, which was way too late, in my opinion. But they did not, at that hospital, want physical therapy involved during when a patient was mechanically vented, which is like ventilated, excuse me, which is so far behind what we know about early mobility in the ICU.
Right.
And so we did that case study. And when I tell you that it was rejected with flying colors, it was one of those rejections where it was like, you're free to submit anywhere else,
Yeah.
right? And that's just how, like, I have to say that publicly, Dr. Khan, because I thought up until that point I was a pretty good writer. But the list of just the laundry list of just information that I guess we didn't include in the report that they wanted was just did not meet the minimum bar for that that journal. And I was including the testimonial from the mom. She had written a letter that she had gone back into school to become a nurse because she wanted to give back after her experience. You know, she had since become pregnant with her second child. Like, I'm just kind of like including what I would do from a branding perspective. Look how great the field can be for this person. What I had written, though, was not even minimum bar for a research publication. And so that's where we are. We have clinicians with these huge hearts that are helping people that are getting these testimonies. And yet, if we are just 6 degrees of separation away from this becoming standard of care, if this is what we need, then the researchers have to be on our team as clinicians. We have to understand the language and we have to know how to communicate with hospital administrators. And someone like you on our team would be immensely valuable just to even get into why that was rejected and how not to
Yeah.
have that experience happen again.
Yeah, you brought up such a good point. Yeah, absolutely. Collaborating researchers and clinicians. Absolutely.
Right. So, what do we need to do to go from here, Dr. Khan? In terms of the research that you're doing, how can acute care therapists who are actually working with this population collaborate with you and other researchers in this area who want to improve maternal health outcomes?
Oh, well, if there is anybody who is currently doing that and would, like to be a part of this, definitely contact me because I would love to help in any way I can. I can
Okay,
come.
so Dr. Khan, so if I have an acute care therapist who's an occupational therapist who just started a program and they are seeing that narrow population, maybe just this parameter of people after cesarean section, not all births, but they want to either publish data just to show that their outcomes, right, are to show what their outcomes are. Would
Mhm.
you recommend they contact someone like you or other researchers in the field that you're aware of?
Yeah, so I would recommend that would be a good step. I mean, obviously, they would be going through the IRB of the medical institution that they're employed at. Um, but there are other ways that we can navigate that as well. So I would say, yes, if you can reach out to a researcher who is in this arena as well, or if you would like to contact me or just to ask some questions, I can also try to help as best as I can. But that would be a great first step.
Now, Dr. Khan, now just to kind of recap, an IRB is not necessary if they're doing a simple case study. Is that correct?
So if they are doing a case study, like let's say they're looking at data that's already through OT services that have already been provided, then no. But if they're hoping to work with individuals in the near future, then most likely I would recommend them going through or at least discussing it with the IRB to see if it's necessary to go through approval because it may.
Excellent. And so, do you provide anything in terms of just education to the clinician who is not, does not have a strong background in research or anything like that? Do you provide any kind of like, here's a laundry list of things to do, here's how you get started, here's how to actually make your practice meaningful outside of your hospital so that more people can understand what you're doing?
Yeah, I can provide general mentorship, me personally. And I can, if there are questions that come up regarding manuscript writing, I can help in that area.
That is awesome. Awesome. Okay. Well, Dr. Khan, how can people get in touch with you? What are all the places you're in these days? I see you a lot on LinkedIn. I
Yeah.
see you releasing your publications and actually telling people about it, which I try to encourage a lot of, writers and authors to do, because we don't know what's out there until it's right in there in front of us. How can people reach you?
Yeah, I can also put my email. I'm not sure if it's helpful to put it here in the chat, but if you wanted to email me, I can provide my email. It's scon@usa.edu.
Absolutely. Yes, go for it. It should show up after we close out this stream. And again, what are you hoping to see in the field in the next 5 to 10 years? What's your closing remarks for people to know about occupational therapy practice and maternal health?
I'm definitely hoping to see a lot more occupational therapy referrals in hospitals, specifically after birth and delivery. And I'm hoping to see a lot more clinicians in the arena of women's health, including maternal health in general. And it would be great if occupational therapy programs were integrating women's health and maternal health into their programs as well.
Excellent, excellent. I'm just going to read a comment that came in from one of our viewers via Facebook, thanking you and also just our collaborative efforts in bringing occupational therapy to maternal health care, especially in hospitals, just like you said. This person is seeing the same issues in their role in a nonprofit connected to birth trauma. The challenges in interprofessional relationships and understanding of one another's roles seems to be a huge barrier in birthing persons accessing services they need. That is so true. Um, Definitely, Dr. Khan, release your information out into the world so that people can find you. And I can't thank you enough for joining me this afternoon, just speaking about this issue. This is really, really important.
Thank you so much. And it was a pleasure speaking with you too. I'm so happy we were able to connect. Thank you.
Same here. We'll talk soon.
Okay. Bye.